This podcast is for educational purposes. Our guests aren't scripted and are free to speak their minds. Therefore, their views and opinions don't necessarily reflect those of BridgeBio Pharma. Also, your doctor is your best source of information about any symptoms you might be experiencing. Please consult a medical care professional about any health questions and concerns. Now, we hope you enjoy the podcast.
Hi, and welcome to On Rare, a rare disease podcast produced by BridgeBio, a biotech company that works on developing treatments for rare diseases. At On Rare, we explore what it's like to live with rare diseases, from getting a diagnosis to the challenges of daily life. I'm your host, Mandy Rohrig, and I'm joined by my friend and colleague, David Rintell.
Hi, Mandy. So nice to be doing this podcast with you today on a beautiful sunny day in Boston, Massachusetts.
It is. It's lovely today. We're on location for this podcast in Boston. We are going to visit with Charles, who lives with ATTR amyloidosis with cardiomyopathy.
And we're really looking forward to speaking with Charles, who's a very interesting man. He is a cardiologist, and he played an active role in his diagnosis. It'll be so interesting to hear about that. But we're going to first speak to another cardiologist who is dear to our heart, Jonathan Fox, who's going to give a brief medical explanation of ATTR-CM.
So it's very exciting. We have two cardiologists on the podcast today.
So let's turn to Jonathan. How are you, Jonathan?
I'm well, David. Thanks for having me back.
We love having you. You're a wonderful teacher, and I always look forward to our conversations.
Well, thanks for the compliment.
Jonathan gave introductions for previous ATTR podcasts, that of Sean and Eric. And there's a whole episode of On Rare featuring just Jonathan talking about ATTR. And I really highly recommend it. Before we speak to Charles, I wonder if you could just give us a brief summary of what ATTR-CM is and how it is that some people develop it.
Sure. Well, for those of you who may have heard some of the prior podcasts that I participated in, you can go get yourself a cup of coffee or whatever else you might wish to do while I tell you the following if you haven't heard this before. Transthyretin amyloidosis is a systemic disease, meaning it affects tissues and organs throughout the body. It's caused by the misfolding and the clumping together of transthyretin, which is one of the 20 most prevalent or abundant plasma proteins made by our liver that circulates in the bloodstream. People who either have destabilizing mutations in the gene that encodes transthyretin or have some features associated with aging that governs the proper synthesis and folding of normal proteins can develop this disease. So I like to think of it in common terms, and the way I often describe it to people is it's a disease of schmutz. And for those of you who are udophiles, schmutz is, clumps of goo or gunk. And that's pretty much what transthyretin amyloid is. It's this misfolded transthyretin clumps together. And when it's deposited in the heart, it causes a cardiomyopathy or a disease of the heart muscle. The other or more common presentation of transthyretin amyloidosis is polyneuropathy, where the schmutz gets deposited in the sheaths of peripheral nerves that control sensation and knowing where your body is in space, or motor nerves to control muscle activity. And it can also affect the nerves that control blood pressure and digestion. So people with ATTR polyneuropathy can have any sort of mixture of all those things. And people who have ATTR cardiomyopathy typically present with heart failure. So it turns out that we've gotten a lot smarter in the last 10 to 20 years on how to make the diagnosis as early as possible. And now we know from some very good clinical trials that early intervention is the key to either stabilizing this disease or, as data are now starting to emerge, to perhaps even regress the disease. In other words, it's sort of like when it rains and it forms puddles, you need the sun to come out. And if it keeps raining and there's no sun, that puddle never dries up. But if you can stop the rain, or the leaky faucet if you prefer, then that puddle, which is the schmutz in the heart, might eventually get mobilized and taken out of the heart. That's an area under some investigation and perhaps a bit controversial, but the field seems to be making progress in that direction. So how do we make an earlier diagnosis? Well, probably the most important single component is somebody has to think of it as a possibility. If that doesn't happen, then the right tests aren't ordered and performed, and the person may go on with a diagnosis of, well, you have heart failure, let's treat you with heart failure drugs and we'll hope for the best. And that's kind of where we were until not very long ago.
Jonathan, thank you. So what happens to people who develop ATTR-CM and their diagnosis is really, really delayed?
Yeah, I'm sad to say it's usually not very good. There are lots of examples in the literature of other kinds of heart disease. Often the case that the sickest people actually benefit the most from some of the drugs and interventions that we have available now to treat those other sorts of heart diseases. But the earlier we can intervene in ATTR-CM, the better people do.
So early diagnosis is becoming more and more important. And again, hear what happened with Charles. And although it's not fortunate to be diagnosed with heart disease caused by ATTR, it is fortunate to have an early diagnosis, it sounds like.
It's critical.
By the time someone's experiencing red flags, either carpal tunnel or the others that you indicated, the disease has already started and is pretty far underway, correct?
Yeah, I would say yes and no. So, and we know from studying people who are alive and living with ATTR-CM that the amount of amyloid that is deposited and accumulates in the heart prior to serious symptoms is a lot. And that goes along with what I mentioned earlier, that people who are caught very, very early, where they might not even have very important symptoms of heart failure, they benefit the most from early intervention with a disease-modifying drug.
Early intervention is the key.
Yeah, early diagnosis and early and sustained intervention. Again, my idea about the turning off the leaky faucet and having the puddle dry up, maybe that's work for the future that's ongoing.
Jonathan, this is so interesting, and we're so grateful to share your experience and insight with us. The ATTR community has got to be really grateful that you have been working so hard to help and improve the lives of people with ATTR-CM. So thank you so much.
Well, thank you. It's been my passion for the last 8 years working on this project. So
it's great to hear that there is so much hope and optimism that early detection can potentially provide for people living with ATTR. Now, here is our conversation with Charles on location from his house in Boston.
Thank you so much for joining us today. Could you tell us a little bit about yourself?
Well, I'm old. I grew up in New Jersey. I went to school in Pennsylvania. I did a medical residency in Cleveland and came to Boston to do cardiology fellowship. And I've been here ever since. Mm-hmm. When I was a kid, I was a New York Yankees fan. And we went to Yankee Stadium to see some of the greats. Mickey Mantle, Yogi Berra. I never saw Joe DiMaggio.
Roger Maris, did you see him?
Yes, Roger Maris, Phil Rizzuto, those great Yankee teams. But since I've been in Boston, I've been a Red Sox fan, which is very different.
And there's no room for Yankees fans.
No, I
made pretty clear as you crossed the border.
That's true.
And you're a cardiologist.
I am a cardiologist. I'm trained both in internal medicine and cardiology.
And you've since retired?
I retired in February of this year after 53 years of practice.
Wow. And since your retirement, how has your life changed?
Well, for one thing, I don't need to commute to Chelsea. For another thing, I'm not responsible for patient care. I've given up clinical practice, but not medicine. Right now, my time is taken up doing volunteer work. So one of the things I do is work in a free clinic in Framingham, where I do see patients. So I see very few patients. And I volunteer for several nonprofit organizations, one of which is called the MAVEN Project, M-A-V-E-N. The MAVEN Project connects specialists like me with primary care providers in clinics that serve underserved populations, such as free clinics, federally qualified clinics, Indian health, rural health, that sort of thing. And so we do a lot of e-consults. Through the platform, I get a case. I answer whatever the question is. I do some teaching on that platform, and I am a mentor to 2 nurse practitioners. The other organizations that I'm involved with are the Amyloidosis Speaker Bureau, where I have given presentations to medical students and medical residents talking about the condition that I have, which is cardiac amyloidosis. And I have been in contact with the Amyloidosis Research Consortium. We're working on a presentation to hand surgeons, the reason for which will become clear as we go on in this conversation.
So you've retired from the professional practice of medicine, yet you have not retired from helping people living with cardiac illness or who are healthcare providers.
Yes.
And many other ways that you're helping people as a volunteer.
In addition to which, I do some teaching at the Beth Israel Deaconess Medical Center.
Excellent.
I teach electrocardiographic interpretation to medical students and residents.
Well, let's turn to your own story, if we could, Charles. So where does the story of your cardiac amyloidosis begin?
It begins in my wrists, tingling hands. That is to say, I had carpal tunnel syndrome. I have it on both sides. My right hand was so troublesome, the symptoms were so bad, that I couldn't use a computer mouse for more than 10 or 15 minutes without stopping. That became worse in 2019. I think it was probably present for some time before that. But by the end of 2019, it was really so bothersome that I went to see a hand surgeon. And she told me that the best treatment would be to repair the carpal tunnel. The carpal tunnel is a structure in the wrist where the median nerve goes under a ligament. If the ligament presses on the nerve, that's what causes symptoms. So I had carpal tunnel. She decided to operate, with which I agreed. But I did remember that I had seen an article in one of the cardiology journals where a group at the Cleveland Clinic did a biopsy of the tissue in addition to the carpal tunnel release. And they found that 10% of the patients had positive biopsies. So I asked the surgeon if she would do a biopsy on mine, which she did. I should add that right after I saw her, the pandemic started, and I didn't get to the operating room until June. Amyloidosis patients have all these weird symptoms that don't seem to add up. They see doctors, doctors don't know what it is, and so the diagnosis is delayed. In my case, the only delay in the diagnosis was because of the pandemic.
So you asked the hand surgeon to take a sample of the tissue, and you said that 10% of the tissue when carpal tunnel surgery is done is positive for some type of amyloid.
That is correct. Well, in my case, it was 100% because mine was positive. Mine was one of those positives. Mm-hmm. Subsequently, it's more common. The Cleveland Clinic data more recently is about 17%. Some Leahy Clinic data is 27%. So it's more common than people think.
So you find out about the results, and what's your next step?
So the next step was to do an echocardiogram. Then I had a cardiac MRI, and that showed findings which were consistent with cardiac amyloidosis. Then the next step is to do a blood test to look for light chains to make sure that it's not the AL amyloidosis that's like multiple myeloma. Mine was negative, so it wasn't that. Then I had a pyrophosphate scan, which is a nuclear scan, and there was a significant amount of uptake in the heart, which proves that I had what's called ATTR cardiac amyloidosis of the wild type.
Meaning?
Not genetic, not hereditary. It used to be called senile amyloidosis, but because it takes place in older people. It's a disease of old men. But I object to senile because it has other implications.
Agreed. So I have to ask, you're a cardiologist. You find out that you have a possible indicator for heart disease from the carpal tunnel surgery. Mm-hmm. And then you're undergoing all these cardiac tests, and the tables are kind of turned on you. You've been treating patients with heart disease your entire career, and now you're the patient. So what was that like for you?
Well, my initial reaction was twofold. The first part of the reaction was the biopsy is positive. It was not devastating. I didn't react in that way, as other people do, but I didn't. And my thoughts were, well, let's do what we need to do next. The way I would approach any other medical problem, any other symptom, what do you do next in order to make a diagnosis? That was one part of the reaction. The other part of the reaction was, oh, shit. So ever since then, I've had to take medication, so then I became a patient. And just like all of my patients and all other patients, if you are prescribed medicine, you have to go to the drugstore and get the medicine or have it delivered, have some method of being sure that you take it on a regular basis. In the morning, I set my alarm at 9 o'clock, so I take it so I don't forget. At night, I don't forget because I do it when I brush my teeth. I'm taking medication not only for the ATTR, I'm taking medication for atrial fibrillation in order to prevent stroke. There are other drugs which treat the condition.
So your first approach was kind of practical. All right, well, I have this finding, so what is the logical next step? Like, I presume in your clinical practice, take it from one step at a time, or, I was thinking of Dr. Spock on Star Trek, who, would take things very rationally. But on the other side, I was about to say, well, what were your thoughts and feelings about being diagnosed with cardiac disease?
Well, I've already expressed myself.
You already expressed yourself, and I want to give you the opportunity to elaborate on oh shit, if you like.
Well, it's a significant condition. I realize that. Being a physician and having access to the medical literature, I was able to look up all of these various articles about what the outlook is and what the treatments that are available are, and there weren't very many. There was only one at the time. At the time I was 82 years old, so if I'm looking at the 2 or 3 year survival, I'm not going to see my grandchildren graduate from high school, for instance. And so that's, I guess, anxiety provoking is probably the way I put it. I never felt what other people have described as being devastated by a diagnosis. I've never felt that way. But nevertheless, I think about it a lot.
It's a life-changing diagnosis.
Well, it really is life-changing. Yeah, it really is life-changing.
So, just to go back to your story, you received your diagnosis, you went on medication, a variety of medications to treat your cardiac illness, and then how else did your life change living with ATTR?
Well, it was also the pandemic. And to be honest, the pandemic had more of an effect on our lives than anything that I had. I have never had shortness of breath, which a lot of people do. My ankles swell, so I watch my weight every day and I watch my salt. Prior to that, I had been taking blood pressure medicine, which I had to stop because my blood pressure was too low, which is something that happens in this condition. But my life in terms of social interaction, in terms of ability to, well, I kept working for one thing, and I continued to run. I consider myself a runner. I don't know if others would. Depends on how you define running. Right. One definition is if both feet are off the ground, you're running. The other one is if you can't run a 7-minute mile, you're jogging. So I'm a jogger, and I've been doing that for 45 years. My running times are not as good as they used to be, but then again, I'm 4 years older, so I don't know that that's my condition. Oh, well, one question that I had when I got the diagnosis was, I wanted to know whether I could keep running. That was important to me. So I have come to know one of the directors of the sports cardiology clinic at Mass General. So I communicated with him. One of the advantages of being a physician, being a cardiologist, is that I know people. So I sent him an email. Should I keep running? He said, absolutely. So I do.
So speaking, well, you knew a lot of cardiologists, being a cardiologist. I wonder what your interaction was like with your cardiologist after your diagnosis.
I had been working at the Beth Israel Clinic in Chelsea. Those who don't know where Chelsea is, it's on the other side of the Boston Harbor, just north of the airport. And so I was working out there, and he would come out there, stop in to see him, chat. I sent him a few patients, and so it was sort of natural for me to ask him to be my doctor. And he said yes.
So it was someone that you knew and was a colleague?
Yeah, a colleague that I knew. For many people, the doctors that they have access to don't know a lot about amyloidosis.
So going back to your biopsy for carpal tunnel. Carpal tunnel is a pretty common condition, and it's often treated with surgery. And I'm going to guess that most people would never imagine or think of getting a biopsy or requesting a biopsy for amyloid tissue. And I'm also guessing that most surgeons do not routinely take biopsies.
The general public doesn't know this unless they have been consulting with Dr. Google.
Or reading journal articles.
Yeah, well, which they can't get access to. But I think the hand surgeons are the ones that I have no information about how many of them are aware of this diagnosis. One of my missions in life is to improve that. With the Amyloidosis Speaker Bureau, I put together a presentation on carpal tunnel syndrome and cardiac amyloidosis, the hand and the heart. When is numbness of the hand a window on the heart?
Oh, that's wow.
So I put that together, and I have been in touch with the hand surgeon who is in charge of education for one of the hand surgery associations. We're working on putting together this presentation that they can put into their video library. One of my missions is to get the hand surgeons more involved.
And if you hadn't been a cardiologist and hadn't read that article, and were just a member of the public, what do you think the chances would have been that you would have gotten a diagnosis when you did? Slim to none. So many people are in that situation now, that they
I'm
get
sure.
surgery for carpal tunnel, and then what would happen? I imagine they'll start having cardiac symptoms.
Exactly.
And that the time to diagnosis would be much longer.
That's true. In the literature is something like 5 to 15 years.
Wow.
If I had not been a cardiologist, or in fact, if I had not remembered that article, which was 2 years before, the diagnosis would have been delayed, I don't know how many years.
And the tough question is, you mentioned that after diagnosis, and in particular without treatment, that the life expectancy is very much shortened. So is it possible that people who do not get a diagnosis early enough may die without ever getting the diagnosis?
True. It is possible. If you have symptoms and high, what are called biomarkers, the blood test results, then your outlook is much worse than if you do not. I'm fortunate to have had the diagnosis at a time before I had any of these that have been associated with worse prognosis. I have diagnosed ATTR cardiac amyloidosis in a number of patients. Actually, I have referred them to my doctor who runs the amyloidosis program at Beth Israel. And I've also looked for it. The biblical injunction, look, what is it? Seek and ye shall find. Right from the Bible. Seek and ye shall find. And that is definitely true with regards to cardiac amyloidosis. The more testing that's done, the more the medical profession will find, the cardiologists will find, and the more people will be eligible for and receive disease-modifying medication.
Mm-hmm.
There are people who have heart failure that is beyond treatment. That is to say, they have not responded to the standard treatments for heart failure, and they're getting sicker and sicker and sicker. Some of those people will undergo heart transplant. Mm-hmm. Now, if you're close to a heart transplant, I think taking the medicine isn't going to make any difference. A friend of mine who lives in Framingham, mm-hmm. who's part of the Framingham study.
The Framingham study is a very famous heart study.
Yes, it was started in the late 1940s and is the study that is responsible for the concept of cardiac risk factors. They studied people and then figured out that smoking, high blood pressure, diabetes led to heart disease. So he had heart failure. His breathing was so difficult that he couldn't finish a sentence without gasping. At which point I told him to go to the hospital, which he didn't. That was friendly advice. So you see, this is the difference. But it turns out that he showed me an EKG from the Framingham Heart Study from several years before, which was characteristic of amyloid cardiomyopathy that I recognized.
But they hadn't recognized it.
Well, they recognized that it was abnormal and told him to see his doctor, which he did not do.
Yes. So I'd like to just ask a question in a kind of different area of life. You have a partner, a significant other named Jane. You've mentioned her. Do you feel like your diagnosis of ATTR with cardiomyopathy, do you feel like it's changed your relationship with Jane, or how has it changed it? Or
I do not. I don't think our relationship hasn't changed.
And you mentioned grandchildren, so I'm going to assume that you have children, or at least one child.
I have 3 sons.
Okay.
Jane has a son and a daughter.
And your relationship with the younger generation?
No, not really, because my overall condition has been with minimal symptoms. My only current symptom is a little bit of residual carpal tunnel on the left and ankle swelling.
I'm really pleased to hear that.
Oh, thank you.
I guess I have one other question. So I know that you work to educate healthcare providers, and in particular hand surgeons, and make them more aware of the importance of biopsies for carpal tunnel surgery. And I wonder if you think the effort is worth it in the general population to let people know that if they do have carpal tunnel surgery, that they should ask for a biopsy.
I'm not sure whether it's worth it to educate the general population, because this is a relatively rare condition. I'm calling it relatively rare as opposed to rare because it's being found more and more. And most carpal tunnel syndrome is not from amyloidosis. So if you take the general population, it's a huge number of people. The number of positives, if you want to call it that, in that huge number is going to be higher than if you only took people who had biopsies. See, but whether to educate the entire world, I'm not so sure.
Yeah, it's a pretty big undertaking. Charles, you mentioned being part of the Amyloidosis Speakers Bureau, and that is connected to an organization called Mackenzie's Mission. Can you just tell us how you got involved with Mackenzie's Mission and the Speakers Bureau and how it's been?
I was introduced to Deb Bodeker and then to Mackenzie Bodeker through a cardiologist at Tufts, who I guess was her cardiologist. After I retired, I spoke with a friend of mine who is teaching at Tufts, a friend of mine who was a colleague at Beth Israel Deaconess Medical Center, which is one of the Harvard teaching hospitals. He was teaching at Tufts, and he had told me that if I ever wanted to get involved, I should let him know. So I let him know, and he then connected me with the Bodekers and the Amyloidosis Speaker Bureau.
Great. And how has it been being a speaker?
Oh, I love it.
What is it like for you traveling and giving these talks?
I have 3 passions: running, traveling, and teaching.
It's really been a pleasure talking to you. Your story is interesting and important for people to hear, but just all of us need to learn more about this not quite rare condition called cardiac amyloidosis.
Yeah. Oh, thank you.
Wow, I can't believe he diagnosed himself with a paper that he had read some years prior. Isn't that fascinating?
Yeah, I think Charles was even surprised himself that he remembered the paper, because it sounded like it was one of the academic papers that come across the desk of a physician, of a practicing physician who's trying to keep up with the literature, but you don't always take all of that in. One thing to remember is that most people with this condition go through a long diagnostic odyssey where they have the condition with some symptoms for a long time and it's not identified. And for a long time, people were diagnosed with heart failure and there was no reason to pursue further testing.
We learned from Charles that oftentimes if people are not diagnosed, then they're managed as if they were a person who has heart failure, and the outcomes are not as favorable because the underlying cause is not known.
So Charles's ability to identify the need for the biopsy was very, very important. And since his experience, he's really dedicated himself to educate physicians and medical students and others about the need for biopsies for surgery for carpal tunnel syndrome. And I think he said that in 10% of the cases where biopsies are done, it turns out that carpal tunnel syndrome is related to ATTR-CM.
And it might even be higher than that. He's quite active and quite busy teaching, educating people on ATTR, volunteering for a speakers bureau through Mackenzie's mission. He's very active in the community.
And he still sees patients on a voluntary basis, which is fabulous. And lastly, he's a jogger. And
He is.
We actually met him at the Brookline Reservoir just outside of Boston to watch him jog on a beautiful fall morning.
And he was getting ready to run 2 miles.
Which is pretty good for anyone who's about to turn 87 years old.
Yes, I agree.
He's a truly impressive man.
Great pleasure to get to spend some time with him.
And we learned so much from talking to him.
Thanks, David. And thanks again to Jonathan and Charles for helping us to better understand ATTR. And thank you to our exceptional producer, Amy Brooks. If you like this podcast, please subscribe and write to us with any questions or comments at onrare@bridgebio.com.
I also wanted to thank our colleague, Alyssa Galloway, who with very short notice was able to connect with Charles and invite him to be on the podcast. So thank you, Alyssa.
Thanks, Alyssa.
If you're interested in learning more about ATTR amyloidosis, here are some of the organizations that connect patients with each other and provide information. The first is Mackenzie's Mission. We're really appreciative of their work. There's also the Amyloidosis Foundation, the Amyloidosis Support Groups, and also the Amyloidosis Research Consortium.
Thanks, David. And thank you for being with us today. And we look forward to you joining us for our next conversation on Rare.